Hello everyone, my name's Michael Langley. I'm introducing the first of the PHIN webinar program brought to you by the Pacific Health Information Network. Thank you for joining us. This is the first webinar in what will be an ongoing series of webinars brought to you by PHIN. They'll be coming to you on a monthly basis. Today we have the first webinar, which is Coding and Classification in the Pacific, an introduction. So just take you through the program for today. We are hoping to have Dr. Ali Hakim from the World Health Organization to make an introduction. Then we'll be having two presentations. First will be Capture of Standardized Health Information through Clinical Coding, brought to you by Sue Walker from the Queensland University of Technology. And then we will have the second presentation, Terminologies and Classifications, SNOMED CT-AU and ICD-10-AM use in Australia by Vicki Bennett. We will then follow that with a question and answer session. Before I introduce Dr. Hakim, I'd just like to take you through some housekeeping rules. If you could, please turn off all your microphones if you're not presenting, and note that the meeting will be recorded and we will distribute it at a later date.
Oh my goodness.
Hello, can you please mute your speakers if you haven't already done so? I can hear somebody. And if you have any questions, please share them in the comments box that is available. Can everybody hear me well? Good, I can see some nodding heads, that's all I need to know. Okay, I'd like to introduce Dr. Ali Hakim, who's the team coordinator from Health Systems Division, Pacific Technical Area as technical support in the World Health Organization. Dr. Hakim.
Michael, this is Katri from WHO. Unfortunately, I think that Dr. Hakim is still at the management meeting, but he have asked me to jump in and cover him. So I'm just, hello everybody, my name is Katri. I'm working with the Dr. Hakim here at the Health System Division of the Pacific Technical Support at the WHO and covering the Pacific. What we would like to say that, you know, WHO has been working the long time for the ICD and setting up the standards and coding in the Pacific, and we have been working for the years, partners, especially with the mortality coding with the Brisbane Accord Group, with the various partners, Queensland University of Technology, Australian Institute of Health and Welfare, SPC, and Australian Bureau of Statistics, the mainly of, you know, the most closest partners. In last year in a PHIN meeting in 2019, we were reviewing, you know, some of the coding issues, and we realized that, you know, it's been very past due that, you know, the countries have had their license, the patent for the ICD-10-AM, allowing the morbidity coding and doing the procedures coding in the Pacific. And we decided, you know, to ask, you know, if our Australian the friends, you know, like would be able to waive, you know, the coding license again for the Pacific countries. And it was a successful initiative, and I would like to especially acknowledge the ambassador for the regional health security of the DFAT, Stephanie Williams, and Vicki Bennett from Australian Institute for Health and Welfare, facilitating this process, and Health Information Managers Association, HIMA. And the biggest thank you is Australian Hospital Authority, you know, like, you know, the waiving the license. But and not talking no more, I would like to give the floor the colleagues of the Sue Walker and Vicki Bennett, and walk us through about the ICD-10 coding in the Pacific, what the Australian licensing means, and how you can benefit out of it, how you can access it, and what means the SNOMED CT and its use together with the ICD-10-AM. Thank you so much, and enjoy the webinar. Over to you.
Thanks, Katri. I will just introduce Sue. So Sue's going to be giving the first presentation on the capture of standardized health information through clinical coding. Sue is the Senior Lecturer in School of Public Health and Social Work at the Queensland University of Technology, where she has responsibility for coordinating the undergraduate degree in Health Information Management. Sue has been at the QUT for 25 years and has been involved in teaching and consultancy and research. Much of Sue's work involves engagement with donors, the WHO and governments to offer short courses to participants from ministries of health and statistical agencies. Sue has worked in a number of Pacific countries, including Fiji, Tonga, Guam, Samoa, Solomon Islands, and Federated States of Micronesia, beg your pardon. So I will stop sharing my slides and hand over to Sue. Thank you.
Thanks, Michael. So just let me pull up share my screen before we start. Okay, so hopefully you can all see that now. So thank you very much for the invitation to speak at this inaugural webinar for the Pacific. And the title of my presentation is Capture of Standardised Health Information Through Clinical Coding. Before I start, I would like to just acknowledge the traditional owners, the First Nations owners of the land on which this presentation is taking place here at QUT. QUT staff pay respect to the elders, laws, customs and creation spirits of our First Nations owners. We acknowledge the important role that Aboriginal and Torres Strait Islander people play within the higher education community, and we specifically acknowledge the Turrbal and Yugara peoples as the First Nations owners of the lands where QUT now stands. So let's talk about coding. So to start with, what is clinical coding? It's basically taking text that has been written by a clinical staff member and turning it into alphabetic, numeric, or alphanumeric codes. We use a statistical classification to do that so that we can order our health data into groups. There are a lot of people all around the world who spend an awful lot of time assigning codes. Why do we do that? Well, firstly, once you've got coded data, it's much easier to store that information, it's much easier to retrieve it and to analyse it. And if we can do those things, we can produce statistics that tell us something about what's happening in our health system. And if we all use the same classification, we can compare our data between different hospitals, different states, different islands, different countries, and across time. And the information gives us important knowledge that helps us to research particular diseases. It gives us information for epidemiological purposes. It allows us to assess public health. And importantly, the data can be used to support the management of our health system, to support planning for health services, to quality assure what's happening in the health system, and to understand who is using our health system. And in many countries, the data that's produced through coding is used for underpinning the allocation of healthcare resources, both financial and people and goods and services. So this slide, I think, sums up in a nutshell why it's important to code. If we have documentation about how patients are treated or how people die, that's important, but unless it can be accessed and analysed and used, it's really pointless. So coding the data is designed to support improvements in patient care and management of the health system, because ultimately, if we have better information, that enables us to make better decisions, and that enables us to improve the health of our populations. Now, what I'll be talking about today is mortality coding and morbidity coding. So let's start with mortality coding. So mortality coding is all about coding the causes of death that are reported on a death certificate or other form. Now, normally causes of death are reported by a doctor or some other official who has been designated with that responsibility. In some countries, if there is a death that is unusual or unexpected, it might be investigated by a medico-legal officer or a coroner or somebody like that. And in other countries, particularly those where there is not a doctor on site, causes of death might be reported by a process called a verbal autopsy. In all of these circumstances, what we are trying to identify is the underlying cause of death for that person, and it's the underlying cause of death that we use for tabulating and reporting our mortality data. So typically, the death certificates which are recommended by the World Health Organization are the source documents that coders use to assign codes to represent causes of death. And then we have morbidity coding. So morbidity coding is all about assigning codes that represent illnesses, injuries, and other reasons why people might come to a hospital or a health service or a clinic. It includes things like screening services, preventive care services, diagnostic services, and treatments. Now, in most hospitals, when morbidity coding is done, any condition that has been treated during a hospitalisation, during an episode of care, will be coded. And from those conditions, the main condition, which is defined by the WHO as the reason the patient came to the hospital, is identified uniquely for reporting purposes. In some countries, we also code not only diagnoses, but surgical procedures and operations and medical procedures. And I'll talk some more about that in a moment. So when we're talking about morbidity coding, the source documents that we use for assigning the codes are the hospital medical records. Now, I'm going to talk about this in a bit more detail. Typically, when we talk about coding for mortality, we're talking about using the World Health Organization version of the ICD-10. So the ICD-10 is the International Statistical Classification of Diseases and Related Health Problems. For morbidity coding, we have options, and I'll talk some more about these in a moment, but just briefly, when we're coding diseases, we have a choice of using the same classification as we use for mortality, that is the WHO version of the ICD-10, or we might use a national modification, such as the Australian modification, ICD-10-AM. If a country is choosing to code procedures and operations, again, we have choices. There's an Australian procedure classification, there's one that comes from the United States, there's one that comes from France, there's one that comes from Canada. There are not lots of options to choose from. So let's start by talking a little bit about ICD-10. So this is the WHO version of the classification. It was first published by the WHO in 1994. And for the first time with this 10th revision of the classification, there has been an updating process that's been implemented. So where there are major changes to the classification, such as the introduction of new codes, those updates are made every 3 years. If there are small changes, such as an introduction of a new index entry, then those changes are made annually. And the WHO publishes the changes and puts them on its website. The reason we have the ICD is because it is used by all WHO member states to report health information to the WHO. So it promotes international comparability and consistency in the way the data is coded, classified, processed, and presented. The ICD-10 is available as a hard copy product, but more commonly it is used these days via the internet, and it is freely available on the WHO website. And I believe that everybody will be getting a copy of these slides, so you will have the link to the website once you get the slides. So what the ICD-10 contains is codes for diseases, for other related health conditions, for injuries, for poisonings. There is a specific part of the classification which is all about coding morphology of neoplasms, in other words, types of cancers. And there is a chapter which is all about causes of injuries and poisonings, which we call external causes. There is another volume, which is a very small instruction manual, and that contains coding guidelines. What the ICD-10 does not contain are codes for procedures and operations. And then we have the ICD-10-AM. So the AM part of the name stands for the Australian modification of the WHO's version of the ICD-10. Now, the Australian modification was principally developed for use in Australia, but other countries have expressed interest in using the Australian modification as well, and it is available under license to other countries to use. The primary responsibility for the ICD-10-AM and its maintenance rests with a government agency in Australia called the Independent Hospital Pricing Authority, or IPA. And IPA has recently agreed to provide a free license to countries in the Pacific to use the 11th edition of the ICD-10-AM. It is possible to obtain that free license by making contact with IPA directly, and I've given you the email address there, and again, once you get the slides, you will have that available to you. So what the ICD-10-AM contains is the same sorts of things as the ICD-10: diseases, injuries, poisonings, neoplasm information, external cause information. But what differentiates the ICD-10-AM from the ICD-10 is it is accompanied by two other volumes. One is the Australian Classification of Health Interventions, which is an operation and procedure classification. And it also comes with the Australian Coding Standards, which are a lot more detailed instruction for coders. So people ask, what's really the difference between ICD-10 WHO version and ICD-10-AM, the Australian modification? Well, the primary difference is that ICD-10-AM is more specific. So the Australian government has added more codes to the ICD-10-AM compared to the ICD-10. Most of the ICD-10 codes are 3 or 4 characters in length. In Australia, we have added some additional 4th characters. We have made some of the 4-character codes more specific by adding an extra character to make them 5-character codes. And there are some completely new codes that have been added as well. But importantly, it is completely compatible with ICD-10 at the 3-character level. So there's still the possibility to do some comparability studies. The ICD-10-AM disease classification has 2 volumes. One is the index and one is the tabular list. So the tabular list is basically the list of all the codes, and the index is the way to find those codes. The ICD-10-AM is updated regularly every 2 to 3 years. We are currently using the 11th edition here in Australia and have been doing so since the middle of 2019. So the 11th edition is the 11th time the ICD-10-AM has been updated. We anticipate the 12th edition will be implemented from the 1st of July 2022 at this point. So as I mentioned, the ICD-10-AM is normally accompanied by 2 other volumes of the classification. The first is what we call ACHI. ACHI is the Australian Classification of Health Interventions. So this is the classification that allows us to assign codes to represent operations, medical procedures, and other interventions that are performed on patients. And similar to the ICD-10-AM, there are 2 volumes. One is the index and one is the tabular list. And then we also have the Australian coding standards. So these build on the WHO version of the rules and guidelines for coding, but they're a lot more extensive than the ones that WHO provides. So I know that in some Pacific countries you already code operations and procedures, and in other countries you don't. So a question that is often raised is, why is it important to also code operations and procedures? Well, the reasons are, first of all, that it gives us a lot more information about the types of health services that are being provided to people in our countries. And it helps us to explain the costs of health services. Coding operations and procedures gives us information that supports decisions about how we allocate resources. And if there is a country that's interested in implementing a funding model called case mix, then it's really important that operations and procedures are also coded. So most often, countries will use, if they use ICD-10-AM, they will also use ACHI, and they'll also use the Australian coding standards. But I'll tell you about your options in a moment. So these classifications and coding standards can be purchased as a book set, hard copy book set, and I've given you the link there to the IPA website where you can actually purchase them. If you buy a book set, the cost is 490 Australian dollars for the 5 volumes. Many people these days use an ebook version. So these are browser versions of the classifications. So rather than having the hard copy books, you have a set of the classifications that can live on your computer. And there are 2 organisations in Australia that actually offer ebook versions, Pavilion Health and Eurofield Information Systems. And again, I've given you the links there. So if you're interested in an ebook version, you can explore what they look like. So we have different classifications. When we're talking about mortality coding, it's important to be aware that any country that is a member state of the World Health Organization is required to use the current version of the WHO version of the ICD-10 for its mortality coding. So ICD-10-AM is really not suitable for mortality coding. You should be using ICD-10 because of those reporting requirements. For morbidity coding, so coding hospital medical records, we have options. A country may choose to use ICD-10 by itself, which would mean that you would be coding diseases, but not operations. You might choose to use ICD-10 for diseases and then implement a procedure classification such as the Australian Classification of Health Interventions to code your procedures and operations. Or you might use the Australian modification of ICD-10, so that's ICD-10-AM to code diseases, and the Australian Classification of Health Interventions for procedures and operations. Now, I can't tell you what's going to be suitable for your country. That is the decision that needs to be made by each country individually. The next thing I wanted to talk about is who should be responsible for the coding. Now, an important thing to be aware of is that when we talk about morbidity and mortality coding, we're talking about 2 different data collections. We have one collection that represents the causes of death, and those causes of death are normally coded by people called mortality coders. And we have a second data collection, which represents the morbidity or hospital data, and that is normally coded by morbidity coders. So in many countries around the world, mortality coding is a centralized function. So death certificates are sent to one central place, either the Ministry of Health or a statistical office, and there is a small team of expert coders who code those using the mortality coding rules. Morbidity coding, on the other hand, may be done at hospital level, or it may be done centrally in a Ministry of Health. What's important to remember is that the rules and guidelines for coding morbidity and mortality are completely different, and they must not be confused. Otherwise, the data that ends up is not going to be so useful. So we need to ensure that we're using morbidity rules for hospital coding and mortality rules for death certificate coding, because then we're using the same coding rules as everybody else around the world that's using the same classifications, so we can compare our data. So when we're talking about coders, these are people who really do have some specialist knowledge. The sort of support that people who do the coding need. Before they start coding, they need some early education. They need to understand some medical terminology. They need to understand some anatomy and physiology. The reason being, when they are assigning the codes, they are reading the clinical documentation that's been written primarily by doctors, and they need to understand a little bit about what they're reading. They don't have to be doctors, they don't have to be nurses, they just have to have a little bit of knowledge in medical terminology, anatomy and physiology. They have to have had some exposure to how to use the classifications and how to use the coding rules to ensure that we're all consistently assigning the codes. They need to understand the mortality coding rules if they are a mortality coder, and the morbidity coding rules if they are a morbidity coder. And it is my strong recommendation that they are not the same people doing both the morbidity and the mortality coding. Because the rules are so different, it is important that you don't confuse the rules that you use for mortality coding and morbidity coding. They need to be done separately. Having had their initial education and started to code, because medicine is not something static, we learn more about diseases and operations all the time. There is a need for coders to have some form of continuing education. Now, that's necessary to ensure they are able to assign the correct codes for any new disease or any new operation that's identified. They need to understand what updates are being made to the classifications. They might need a little bit of extra understanding about medical science. What they also need is good quality source documents. So the quality of the coding is based on the quality of the documentation that they are using to assign the codes from. So if we have complete death certificate data, or we have completely documented medical records, then the coders have a much easier job in determining what needs to be coded and more accurately assigning the codes. So what that means is that people who complete those source documents, so doctors and certifiers, need to understand how important what they write is for coding purposes. So the documentation is, of course, used for continuing patient care in a hospital setting, but as a byproduct, it's also used for coding purposes. So here in Australia, we recommend that there is a relationship between people assigning codes and the people who are doing the documentation. So if a coder has a question about what's been documented because they can't understand the handwriting, or perhaps the documentation is incomplete or inconsistent, they can ask the doctor a question. So that's the end of my presentation, and I see there has been some notes that have popped up in the chat while I've been talking. If you do have any questions about anything that I've presented, please feel free to make a note in the chat, and after Vicki's given her presentation, we'll come back and answer those questions. So thank you very much, everybody, and I will stop sharing my screen now.
Thank you very much, Sue. That was wonderful. So, Vicki, I won't put up my slides. I'll just let you go straight, set yours up, and I'll just read a little bit about you. So, Vicki Bennett is currently the head of the Metadata and Classification Unit at the Australian Institute of Health and Welfare, where she's held a number of different roles over the past 13 years. She was previously the manager of the Information Strategy section at Medicare Australia. Vicki has had a diverse career and worked extensively across the Pacific over the past 15 years. Thank you, Vicki.
Thanks, everyone. Hopefully you can hear me well. I'll just get my slides up. It's lovely to see so many familiar faces out there and names on the screen. I thought I would do my best to give you a bit of my Pacific background. I've got my photo from the Solomons in the background. I've got my Cook Islands tab dress on, my Tongan necklace. So I thought even though I'm sitting in my lounge room and my office here at home in Canberra, I would rather be with you in the Pacific than doing it online, but at least we're able to get together this way, which is fantastic. And thanks, Sue, that was a really great overview of the classifications. I guess this presentation that I'm giving now, and I'd like to acknowledge the Independent Hospital Pricing Authority and the Australian Digital Health Agency, who also helped develop this content, was put together because even here in Australia, people have a difficult time understanding what the difference between health terminologies are and health classifications. And this is a subset, I guess, of a webinar that we've actually done here in Australia a couple of times to help people understand what the differences are between terminologies and classifications and when and why we should use them, and the different use cases for which they have been created. So I will try to sort of keep this quite high level, I guess, rather than getting into too much technical detail, but the slides will be able to be available so that you can have a look at them later. Sue has talked already about classifications. So you can see on the right-hand side there, the ICD-10-AM and ACHI are mentioned that Sue has already talked about. And there are other types of classifications, some of them developed by WHO, some of them developed by other organisations around the world. On the left, though, we are talking about terminologies.
Vicki, I'm not seeing your slides.
Oh. Sorry, thank you. Is that better? Oh, good. There you go. Thank you. Yeah, so classifications is already talked about. Terminology, though, is a set of concepts about a domain that shows how things properties and relationships between them and organises their meaning. So it's about having a codification to help have a shared meaning. I'll go into that in a little bit more detail later, but we're going to talk largely about SNOMED CT, which is the largest or most popular, I guess, terminology. But this slide is, I guess, to outline that the classifications and terminologies that we've talked about today are not the only ones. So LOINC is the one that's mentioned at the bottom there, and that's used widely in pathology, for example. When it comes to sort of thinking about granularity or the level of detail that's in each, terminologies usually are more granular and have more actual clinical terms in them. Classifications are less so, and you might have heard of diagnosis-related groups or resource-type groupings, and they, again, are less granular. So they all have their purposes, and the level of granularity has pros and cons for different use cases. So I'm not going to cover anything more about classifications. Sue's done a great job on that. But I will talk a bit more about clinical terminologies or health terminology. So it's like a dictionary, I guess. It's a vocabulary of terms that is structured, and it brings concepts and it describes concepts that are used in clinical practice that can be implemented in software applications. Terminologies have to be embedded in software, otherwise they don't work. But what it does do is it brings a shared meaning or a standardized meaning of different concepts that are relative to the patient and the healthcare that is delivered to them. So it covers, as Sue talked about in classifications, the ICD-10 covers diseases and the ACHI covers interventions. Terminologies cover both in one set. So SNOMED CT covers both diseases and procedures and everything basically around healthcare. And they are defined by machine readable relationships to other concepts. So the fact that the term diabetes is captured in an electronic health record has no meaning unless we know whether it's a patient history or a family history. So they have to be related to by concepts to have a true meaning. Get rid of my screen because I can't. Here we go. That's better. I couldn't see the right-hand side of my screen for all the beautiful photos of you sitting there. So the reason we use some of these things is that it helps us record structured statements about what's happened. It's really good for communication between clinicians. So there's a term that people use called semantic interoperability, which sounds pretty fancy, but it just means that we have a shared understanding of the communication between two systems. So when I transmit information to another clinician, they get the information in a way that is exactly how I meant it to be communicated. It does allow some data abstraction, and we'll talk about the kinds of ways that we can use it in a little bit. And some indexing and storing and retrieving of clinical data because it is structured underneath. So, as I say, to best utilise our clinical systems and computing tools and apps, we do need structured data underneath that. So you're all very familiar with free text information or freehand writing that doctors do, and the need that we often have to abstract information from that, and that's what we largely do as clinical coders. Terminologies help us structure that at the point of collection, I guess is what a terminology does. And it allows us to have that information able to be extracted from a system, and hopefully therefore leading to better availability and access to that data ongoingly. So people say, why do we need terminologies and why do we need classifications? Well, we are able to certainly structure the data at the point of care, at the data capture, if terminologies are embedded in our information systems. Again, for sharing between clinical information systems and making sure that the meaning is shared and that we can then abstract it for further use later. So again, it's really important that we embed it into our electronic health record systems if you want to be able to capture structured information. And it allows the clinician to enter it in a machine readable format so that it is able to be abstracted. And I guess one of the other good things is it allows that different synonyms for the same term to have be recorded in a way that they can understand, even if people use a different word that's not quite exactly the same in the record. So here is sort of a simple patient record with SNOMED CT-AU coding. We have an Australian modification of the SNOMED international version. SNOMED CT is the international version. SNOMED CT-AU is a bit like the AM version of ICD-10 because we've added things in the Australian version like Vegemite as a concept, funnel web spider as a concept, things that really don't belong in the international version. So that there's some specific things that have been added for the Australian context, but I don't want to sort of reference a lot of that. We've also added into the Australian one a lot of the Australian medicines terminology. Again, that some drugs are not used globally that we perhaps use here in Australia. But here we go, you see that you're able to capture different conditions, like in the problem list there, somebody has asthma, you're able to collect somebody has an allergy to shellfish. Hopefully if you live in the Pacific, you don't have that, because that would be a disappointment. Or in Australia, it could say Vegemite in that category. We can capture structured concepts around different tests that were requested and undertaken, and medications. So as I say, terminology allows us to capture each of those different things in the electronic health record. But as I said, it's really important that it's part of a well-designed electronic health record, because you need to understand that in the problem list, well, no, maybe a better example is that current medications, let's say it said, what have we got there, Ventolin, having it in the medications list as opposed to in the allergy list changes the meaning quite significantly. If you were allergic to Ventolin, it would appear in the allergy section, but if you're on it, taking it as a medication, it appears in the medication section. So terminologies only work properly when it's part of a highly structured electronic health record. Now, this is an example, I guess, of where we can often use different words to describe the same thing. So in the diagram there on the right, the actual SNOMED code for malignant tumour of the kidney is there as 363518003, and you never learn those numbers or use those. That's actually encoded into the back of your software. It actually can mean all of those four things around it. You might call it renal cancer, or you might call it renal malignant tumour, or a malignant tumour of the kidney. So what I guess the SNOMED code allows is that despite what you write in to the record, it all is mapped back to that one code or one concept, regardless of whether people describe it as renal cancer, malignant tumour of the kidney, because they all actually mean the same thing. So that is where it helps our human brains know that they're the same thing, but computers aren't clever enough for that. That's where the terminologies embedded in the back need to help us with that. Now, this is a busy slide and I won't talk through every single part of it, but I guess one of the important things is that to note is that SNOMED is a polyhierarchy, and ICD-10-AM and 10 and a classification is a monohierarchy. Now they are big words, but it means that in the classification, the ICD-10 and 10-AM, items are organised into non-overlapping categories, and no subject can belong in multiple classes. So it allows us to count things uniquely. However, in a terminology like SNOMED, allows items to be defined according to their various meanings. So you can see there that pneumonia can be an infective condition with a pathology, or you can say that pneumonia is also a respiratory infection. And so it allows you to have, a tree with multiple branches where you can go up multiple paths rather than straight up, you can see in the diagram on the right. It does support clinical data capture at the point of care. It's easier to see that a clinician can say, yep, vascular myelopathy, that's what I was trying to write down. He's probably not going to know vascular myelopathy is G95.1. So he's not going to type in G95.1. It has there, and it will automatically, if he typed in vascular myelopathy, pull out the concepts that those words find in the SNOMED term sets. So one of the, as I said, the primary collection of data at the point of care as the way that the clinician enters it, SNOMED is certainly very good for that. It does also allow us to use the data in a secondary kind of way, so that health records can have data withdrawn from them, and health information managers and other health statisticians can actually pull out based on SNOMED terminology. It's an area that's actually developing at the moment, and methods for doing so are being worked on actively. Certainly in Australia, we are doing a lot of work in that space on how to abstract SNOMED terms for use. But as you can imagine, it's much more complicated because you have to understand the referential integrity and keep that, because as I said before, if diabetes is written in the family history notes versus in the personal history notes section, it means quite different things. And so if I go looking for patients with diabetes, I have to be looking for that terms, that SNOMED term, only where it's related to the person's health themselves rather than it be the family history. Or I can't even just look for the term diabetes in the personal history, because it might say no history of diabetes. So contextual information is very important for SNOMED data analysis. So here's an example of how you can actually use ICD-10-AM, for example, to capture clinical information. So it's fairly obvious here. People get coded with, let's say here we've got respiratory tuberculosis, bacterial and histologically confirmed. You can see there's 3 people in that category there, and you can see the 3 people in the 3rd row on the other side. There are 10 people in one, 4 people who have got the chapter 10 conditions of the respiratory system, which you can see there, and 3, I got that wrong. The point of this slide is that we don't double count at all when we use a classification. However, when we do have SNOMED terms, people can be in multiple categories. And for example, you could here again with pneumonia describe someone with viral pneumonia or bacterial pneumonia. They are both, and tuberculosis of the respiratory system. They are all respiratory conditions. But if you look at who's got a bacterial infection, you get 5 people overlapping in both categories. So it depends on what you're searching for. And so if you are analysing or researching something about respiratory conditions, you might want to use the SNOMED terms to look for those people. But you can't say then that, you know, it's the same 10 patients, but they will be double counted, at least 5 of them. So that's where classifications and terminologies are different, and therefore really have different use cases, particularly in statistical analysis. So I guess what the point is to say that SNOMED and ICD-10 have complementary strengths. They are different, they have different purposes, they are able to be used together. There have been some maps developed to map between SNOMED CT and ICD-10. There is a whole bunch of work still going on to do more work in that space, and I haven't included slides on ICD-11 in this presentation, but there is work going on to do mapping between SNOMED and ICD-11. Because I think in the long term, using terminologies, particularly for data capture at the point of care, is an important use case. But classifications are going to and always be necessary for statistical analysis, so we produce good health statistics. So you cannot use SNOMED without computerized records. That is just a given. So if you have a paper-based system, that's, SNOMED is not for you. You can use ICD without electronic health records. And that's really important to note, so that if you are on a journey of implementing or improving health information in your countries, start with classifications. Is my view is that you will get good information in the first instance, and then you will also have the ability to think about how then into the longer term you are able to use potentially terminologies that would be embedded in an electronic health record that you may or may not have in the maybe near future in some countries. I know there's some countries who are thinking about implementing electronic health records. I'd certainly suggest though that you seek advice from someone other than your vendor if you're thinking about implementing these things, because it's not as straightforward as maybe you might think, and you certainly need to understand the impact on your clinical staff, because terminologies are captured at the point of care, and the impact is not necessarily on your HIS, your HIU teams. It would be much more on the clinician side. So it's a very important consideration. Now that's my last slide, so I'm going to pass back to you, Michael, in case you can facilitate some questions.
Thank you very much, Vicki. I know I've learned a lot. So that concludes the two presentations from Vicki and from Sue, and now we are going to have a question and answer session. I know some questions have been coming in while both the presenters have been talking, and some have been answered, but I'm going to hand over to Katri Contio, who is going to manage them by allocating them or whatever way she wants. Are you there, Katri?
Yes, thank you, Michael. I saw that, the Sue has been kind of promptly replied to many of the questions, but maybe we just go quickly through, if people have not read it. So I guess the first question was really, what's the difference between the different national modifications like ICD-AM and ICD-10-CM? And the question was coming from the FSM.
So each of the national modifications has been developed with the country that developed it in mind. So the needs of each individual country have been preeminent in the modifications. So the difference between ICD-10-AM, for example, and ICD-10-CM, so the AM version is more specific than the WHO version of the ICD-10, but the American version, which is the ICD-10-CM, which CM stands for clinical modification, is that much more specific again, because it's been developed for use by the United States, and they had particular things they wanted to be able to report. So the difference is in the level of specificity.
Maybe I can ask additional further question on this, with what came up to one of the discussions with the US APIs, is that they found out that the ICD-10-CM might be too granular, too detailed for them to code for the morbidity given the EMR system. However, they would like to still to do the procedures. So procedure coding, what would be the option for them?
So the American version of the procedure classification is called ICD-10 PCS. PCS stands for Procedure Classification System. It's a proprietary product, and it costs a lot of money to obtain the license to use it. That's my first point. But if a country would like to explore whether or not it's suitable for use in their country, my recommendation would be to contact the people who provide ICD-10 PCS and ask them whether or not it would be possible for a license to be provided to a country for a brief time, just to allow them to try it and see whether or not it's suitable for use in their country. I wouldn't automatically go and spend an awful lot of money. I would ask for an evaluation license to start with.
Thank you. Then one question was from Donald Wilson from Vicki National University. He mentioned that, you know, it's quite common that there's a pool of the coders in the countries are very few in numbers. And many small islands, they are unfortunately the same warm bodies, the same coders has to do the both morbidity and mortality coding. So the really, you know, the why the people need to be the different and how we would be able to overcome this challenge.
Yeah, maybe I can comment on that. Vicki might want to jump in after me. It always has concerned me in the Pacific where there is a country that only has one coder, and that individual coder is responsible for all the coding, regardless of whether it's morbidity or mortality. Why I'm concerned about that is the risk that if something happens to that individual coder, then there is nobody left to do the coding. So at the very least, I think any country needs at least two coders so that they can share the role. So that if something happens to one, if they retire, if they get sick, if something happens, if they go off island, there is somebody to take over. So I think what needs to happen is countries need to have a discussion about how they plan to use the coded data. And if the reasons they're coding the data are important enough that they can see the benefit of having more than one coder, I think they should explore the options. My concern, as I said in my presentation, is the rules are so different between morbidity and mortality coding that there is always the danger that whoever's doing the coding will confuse them. Now, I've done some auditing of some Pacific mortality data, and what I've seen is the morbidity rules being used to code the mortality data, which means that the resulting statistics are completely different to those produced by a country which is using the correct rules. So the comparability of the data is not there.
All right, thank you. I think the last question is for Vicki, for you. It's really about the asking the SNOMED.
Yeah.
The FSM is asking, this is a very tricky question. I could, you know, actually add one additional question for you. When it would be the suitable and the recommended, you know, the countries to consider to using SNOMED, knowing that your EMR should be functional, I guess. And how it can be integrated, and if there's online courses, what would the recommendation for the coding? And I understood that, you know, the doctors who needs to actually, you know, the code is SNOMED. It's not the clinical coders and ICD-10. Over to you.
Yeah, thanks. Look, as I said, you really do have to have a fully operational kind of EMR, EHR type environment to use SNOMED. So if you have that, that's in FSM, that's kind of probably the first step. SNOMED CT, the international version, there are, it's developed out of the US, and you can join as a member of SNOMED International. You can get online, they run online training sessions. It is probably more detailed, obviously much more detailed than anything I've said today. So there is trainings that you can undertake online to get a better idea about how and what it contains and how it can be used. But yeah, I would be talking to your software vendor about whether their application actually can take SNOMED term sets. I guess one of the decisions that, you know, we in some, for example, here's an example where we do use it in Australia, in Queensland in particular. They're using it for, they use a list of SNOMED terms or a code set to capture information about the diagnoses in their emergency department data sets. So it's a very specific subset of the terms that they've embedded into their application that allows only, you know, the kinds of diagnoses. So for example, it doesn't capture procedure information in emergency, it only is capturing the diagnoses. And actually that is mapped to our ICD-10-AM lists, because it's actually used for funding purposes here in Australia, for funding of emergency departments. So as I say, SNOMED, only if you've got an EHR or an EMR kind of environment. If you want to get a more in-depth knowledge about it, there's online training through SNOMED International. I'm happy to link you up with a link to some of those online trainings, and put you in touch perhaps with SNOMED International if that is of interest to you. As I say, we've got a country modification in Australia. As I say, the 100,000 odd, hundreds of thousands of terms in SNOMED is a large set. You know, you don't necessarily need all of that. You can do short lists, so it can be used a bit like a pick list. I know in Fiji, in the PADIS Plus system, you know, there was some code, ICD-10-AM, the 4th edition code set lists that were being used in the outpatient clinic to capture diagnosis at outpatient clinic. SNOMED is probably better for those kinds of things because it allows the clinician to be more accurate in what he writes, rather than having to pick from us one term about, you know, what kind of, you know, fever this was. He can be more descriptive, I guess, with a SNOMED term set. But I guess the consideration really is about what is going to be of use. And I hark back to Sue's point. It's not just about collecting information, it's about what we're going to do with it. And if you don't have a good use case for the data that you capture, then don't put the burden on people to capture data that you won't use later. So I think you really got to consider about, yeah, great to capture, you know, and this is a decision for you about 10 and 10-AM and as well, you know, you've got to understand what use you will put the data that you capture to. That should be informing the decision about whether you go with 10 and 10-AM, SNOMED or anything else. And that is probably the most important, to start at the far end of the screen and say, okay, well, yes, we've got these national reporting and international reporting requirements. So yes, we need 10 for mortality because we have to report to WHO, and that's an easy decision because we know the use case. So, but what are you going to do with the rest of the data? In Fiji, I know one of the reasons we wanted to collect when we implemented 10-AM back 15 years ago was that we wanted to capture some clinical indicators from the hospital, and we wanted to be able to look at safety and quality measures. And one of the indicators was post-cesarean infection rates. Now, we couldn't capture post-cesarean infection rates if we weren't capturing cesarean, the procedure code. So therefore, the ACHI code was really important. So that was a really good use case to say, okay, we can then look at people who've had this ACHI code for cesarean, and then they've also got a diagnosis of an post-surgical infection. So it's those kind of use cases that should be driving your decision around what you're going to implement. And I guess both Sue and I'd be really happy, I guess, Sue, I'm dropping you in, to have conversations one-on-one with any countries who really need to talk this through, because I do think you should be talking it through and including your clinicians in those conversations and your health managers who are going to use the data at the end.
I'm very happy to help.
Okay. Any more questions?
I have actually the one last question from Katri. Sorry if anybody else wants to ask, but so what is really, you know, like the most important, you know, the value, why the country should, you know, start, you know, the reporting the procedure codes? For me, it comes, you know, like first the hospital management and, you know, to do the proper costing, to understand, you know, like what are the operations happening in the hospital. But what would be your view, Vicki and Sue?
Maybe if I can jump in first. Just to elaborate a little bit about what you said, Katri. Health systems, there is a finite amount of money that is allocated to health systems. And we really need to understand how best to use that finite amount of money. So I think it's important to capture procedure information so we can know how many operations we're doing and how much they cost us to do. So I think it's really for management and resource allocation purposes would be my perspective.
I'd add to that as well that if you're just coding a diagnosis, let's say somebody comes into hospital with a diagnosis of diabetes, it's that episode of care is quite different if the procedure code is, if the procedure undertaken is just management of their insulin versus a lower limb amputation. You know, the diagnosis doesn't really give you a good picture about what happened during that admission in and of itself. And particularly as we move to NCDs, you know, the growth of our non-communicable diseases, which often are not just episodic, but they are lifelong kinds of conditions, being able to understand how we are managing that effectively is going to help not only fiscally, but in understanding the quality of the care we're providing to our patients. If you have lots of people having a lower limb amputation with diabetes, you are not managing their diabetes well. You know, if we have people who are living for 30 years with well-controlled diabetes because their medication is managed well and they're managing their diet and exercise, that is a good health outcome. You know, so health outcome measurement sometimes is reflected also in our procedure coding.
Okay, thank you again. Are we all done? While you're thinking about that, I'll just put our slides back up again. And so that's what I was referring to. So again, thank you. And just to say that this is the first in the series of an ongoing webinar program that PHIN plans to bring to you. We have the next webinar scheduled for the 25th of November, and that will be discussing digital tools for a COVID-19 response. So that should be both timely and interesting, I hope. And again, we'll distribute this webinar via the distribution list, and if you don't get it, then you can contact me directly on that email address there, or find somebody who got the invitation. Okay, so I'd just like to thank again everybody for joining us, and ask Chancellor if there's got any final questions. Other than that, hope to see you on the 25th of November.
Thank you, Sue. Thank you, Vicki. Thanks for it.
You're welcome.
Thank you.
Thank you and bye.